Good afternoon, nurses. Today we're going to be talking about PT, INR, Coumadin, and doctor's orders, and this is a presentation that Deborah Howell asked me to put together and present to all of you. So hopefully you'll get something out of this, and as we go through this, and if you see something and you have questions, please don't hesitate to send me an email. So the first thing that we need to remember is that anticoagulants are considered a high alert medication. Nurses need to be knowledgeable about anticoagulants to ensure safe practices, and mistakes can be deadly when working with anticoagulants. And this could be anywhere from a patient falling and bleeding out rapidly, or somebody having internal bleeding, and Coumadin especially not being monitored correctly can cause something to end up, and it could end up being deadly for a patient or a resident here. So Coumadin is used to prevent DVTs, pulmonary embolisms. It's used to treat atrial fib, and it's used in the prevention of stroke. There's some other off-label uses for it, but those are the primary reasons that an anticoagulant is prescribed. So the three main types that we see are Coumadin, which is an oral version, Lovenox, and then heparin. Lovenox and heparin, of course, are injectable medications. Coumadin is the most common oral anticoagulant. There are some adverse effects possible, however. That can include hemorrhaging, GI bleed, skin necrosis. That's usually going to happen within 10 days of the start of therapy. And the other problem with Coumadin is that there's many interactions with other drugs. So for somebody to remain on Coumadin, the benefit has to far outweigh the risk. So if you get a patient who's got a new order for Coumadin and they have 20 different medications, make sure you're questioning that order to make sure that the resident really needs to be taking Coumadin. So the prothrombin time, or the PT, measures how long it takes for the blood to clot. The internalized normalized ratio, or the INR, is developed to standardize the PT values across laboratories. So if I have my labs drawn here in Michigan and I go to Alaska, that number is going to be the same across the board. They've done that because Coumadin is such a high-risk medication, they need to make sure that that level is right where it needs to be. Trinity Senior Living Center assures our residents that while they're here, they're going to have the proper monitoring while they're receiving Coumadin therapy, and all residents receiving Coumadin therapy are going to have a current physician order for lab monitoring of the med. Do not get an order for Coumadin unless you also obtain an order for lab monitoring. This is critical. So when you get an order for lab monitoring for the PT-INR, you need to make sure that the date and frequency of when the INR should be drawn, what the circumstances are when the dose should be held and when the doctor should be notified. The facility should choose the dates when all PT-INRs are done, and the order date should say which. Here at Sanctuary at St. Mary's, we draw labs Monday, Wednesday, and Friday unless a stat lab is needed, and then one of our nurses can draw that lab. Coumadin should be administered at the same time every day. Here at Sanctuary at St. Mary's, that is 8 p.m. unless otherwise prescribed. That is our policy, so if you see an order for Coumadin and it's not listed as being given at 8 p.m., should not say PB or anything like that. It really should say 8 p.m., so make sure that we're checking on that. The diagnosis for the Coumadin therapy should be listed, and the physician's ING goal needs to be listed also whenever possible. So a properly written order is going to have the date on there. So in this case, I used 1/3 of 2014. So the order is for Coumadin 10 milligrams by mouth tonight at 6 p.m. Then Coumadin 7.5 milligrams by mouth today at 6 p.m. So that would be the order for the Coumadin. Then repeat the PT-INR Monday morning every week. Notify the physician if result is out of the 2.0 to 3.0 range, and hold dose if over 3.0. This is being prescribed for post-operative hip and atrial fibrillation, and the target INR goal is 2.5. So this would be a properly written order. Every single time you get every single time that you receive orders back, you need to be calling to get a new order for those labs to be drawn. We also need to encourage our physician to avoid orders that are easy to be confused, such as writing different doses for different days of the week. An example would be something like Monday, Tuesday, Wednesday, give 3 milligrams of Coumadin. Thursday, Friday, Saturday, give 1 milligram of Coumadin. Sunday, give 5 milligrams of Coumadin. We really don't like to see that because we don't want to have errors in our prescribing, and that can very easily happen with that type of an order. So a uniform dosing policy is preferred. We need to notify the physician also for dosing instructions when the resident is on antibiotic therapy or if they have an artificial heart valve. Residents on antibiotic therapy are going to receive INRs at a greater frequency. Usually that's going to be 3 times a week unless otherwise stated by the physician or prescribing or the prescriber. And then residents adjusting, so residents who received a new dosage of Coumadin need to have INRs drawn at least weekly, should be the same time and day of the week. And residents with a stable PT-INR should have INR draws at least monthly. Physicians who wish to deviate from standard practice have the right and ability to do so. However, they must document in their progress notes the rationale for their decisions. If the physician fails to do this, the medical director must be contacted. All residents on Coumadin therapy must have an anticoagulant therapy flow sheet completed and in the MAR. The nurse should never, ever, ever administer a dose of Coumadin prior to checking the last lab result. So every single day on second shift before you give your dose of Coumadin, you should always double check to see if there is a new lab that's been drawn. You also need to make sure that that lab has been called into the doctor and that you're all set to go in order to deliver that dose of Coumadin. On the days that the INRs are drawn, they really should be drawn in the morning, and that way the results are going to be back prior to giving the dose of Coumadin that night. The doctor should have already been notified, and everybody should be on the same page. My apologies for that. So if this is a new admission or a readmit, the results of the last INR should be documented on the anticoagulant therapy flow sheet. So make sure to do that. All residents who receive anticoagulant therapy must have a flow sheet and a care plan in place for them. All sections of the anticoagulant flow sheets need to be filled out completely, and that should include the resident's name, room number, and the attending physician. So that also should be completed on both sides. Second shift, again, is responsible for administering Coumadin, and it is given at 8 p.m. If, in fact, there is an order specifically written from the doctor that it should be given in another time, that needs to be documented as to why and put in the doctor's note. No one should administer Coumadin to a patient without knowing what the current PT-INR is and when the next lab draw date is. Lab results must always be called into the physician. Please don't just write this in the book or assume that it's okay to go ahead because it's within the allowable limits. You always need to call this into the physician, and you always need to get a new lab order for the Coumadin. So when you call the physician with the results, you need to give the physician the lab results along with the current Coumadin order, obtain an order for the next lab draw or a new med order, fill out the anticoagulant therapy flow sheets, and then all columns should be filled out, including the diagnosis and reason for anticoagulants. This should be the same diagnosis written in the lab sheet. If they don't match, contact the physician to find out why. So prior to giving Coumadin, you should always check the flow sheet to verify the last INR and when the next lab draw should be. If a lab draw is passed, you need to either verify that the lab was drawn and call the lab for results, or you may have to do a stat lab order. If you come in and for whatever reason you're looking through the med book and you notice that the labs haven't been drawn, you called the lab and they say, nope, we didn't draw on this patient, you need to call the physician, get an order for a stat lab, get that drawn, and do not administer the medication until you have a lab order back. So until you have those lab results, don't be giving that medication. Make sure to also call the physician with the new lab results once they come in. All residents admitted on Coumadin therapy will require a PT-INR draw on Monday, Wednesday, and Friday for 2 weeks. If the lab results are within normal limits after the 2 weeks, then the PT-INR draws will be weekly. This will be done on Mondays for 4 weeks. If the labs remain normal after the 4 weeks, then the PT-INR will be drawn monthly thereafter. During antibiotic therapy, the patient or resident on Coumadin will have PT-INR drawn 3 times a week. Any and all abnormal PT-INR results need to be called to the physician. If you're unable to make contact with the prescribing physician, you should contact the medical director. And if you're unsuccessful reaching the medical director, you need to contact the director of nursing. I would say that this should happen within a half hour to an hour, especially if this is a critical lab. This needs to be called in to the doctor immediately, because if somebody is in a critical state, we may have to send them out to the hospital, or we may have to do immediate intervention. So this is very important. Okay, so we're going to shift gears a little bit now, and we're going to talk about requesting physician orders. So, when you're working the floor, please don't interrupt the physician while they're with another resident reviewing a chart. Either add it to the physician's book or complete a nursing intervention first. Nursing intervention should be used before a resident is seen by the physician. We need to document the intervention used and the outcome. Residents are charged for a doctor's visit every time that they are seen by a doctor, and this cost can add up. So please make sure it's absolutely necessary when a resident is seen by the physician, PA, or NP. We've had several family members complain about the high costs of doctor's visits when their loved one is supposedly stable. So please make sure that it's necessary for the resident to be seeing the physician. When you get a new physician order, the order should always be double-checked. New orders should be taken care of and faxed to the pharmacy as quickly and efficiently as possible. Physician orders should be transcribed and clarified if necessary. If you get an order and you can't read it, you need to call that physician. Try not to go over to your fellow nurse and say, "Hey, I can't read this, can you?" Because that's where a mistake could happen. Just call the physician and say, "I'm very sorry, I just can't read your handwriting. Can you please clarify this order for me?" Make sure that the pharmacy receives a proper copy of the order and that meds get delivered in a timely manner. If the medications aren't delivered in a timely manner, this can cause a problem for the residents. So when you get a new order, it should include all of the correct information for the order itself. So an example would be lisinopril, 10 milligrams, 1 tab twice a day for 10 days with a start date of 1/15 of 2014, doctor and nurse signature, and this is going to be for hypertension. So when you're transferring physician orders to the MAR, you need to make sure that all the correct information is listed on the MAR, including the reason and diagnosis for the medication, or where the medication needs to be delivered, or how the medication needs to be delivered. You're welcome to come into my office. I have several examples of some poorly transcribed orders that were put on the MAR, and I'd be happy to go over those with you to help you prevent the same error in the future. Please never write that you left a note in the doctor's book or left a new note for the doctor in your nurse's notes. This should not be written. It should always be stated that you communicated this with the physician. It's even better if you have a date and time that you can put in there too, just for accuracy. So we need to speak up because we are our patients' best advocates. If you feel that orders are abundant and can't find a reason or rationale for them, talk to the physician. If you don't feel that the doctor is listening to your concerns, let your CCC know. And if you see your fellow nurse struggling with physician orders or requests, be a mentor and provide them with support. We are all here to work together. Nurses, please make sure that you're checking your email at least once per shift. Deborah and I have been communicating with you this way, and it's very important. We recently had a nurse state that she hadn't checked her email in about 3 weeks. So please just make sure that you're checking that at least once per shift. You're logging in and at least skimming through your messages so that you have an idea of what's going on. And then we also ask that you help your CNAs complete their health stream assignments. They're not able to log in themselves to the computer, and a nurse has to do this for them. So if you can just take the few extra minutes to help them log in and make sure that their health stream assignments are getting completed, that would be great. If you have any questions, comments, or concerns, you can email me at my Trinity Health email address. Presentation is ended, so thank you for watching.